Right. Good afternoon, everybody, and thank you for the opportunity to present today. My name is Natasha White. I'm a final year medical student at the University of Oxford. Today, I'm presenting a systematic review comparing total intravenous anesthesia, or TIVA, with inhalational anesthesia for intraoperative outcomes in colorectal cancer surgery. This week's work was completed with some of my colleagues at the university. For background, colorectal cancer, as you'll know, is one of the most common cancers worldwide, and the surgery is still the main curative treatment for non-metastatic colorectal cancer. There has been increasing interest in whether anesthetic technique influences perioperative physiology and potentially even oncological outcomes. Anesthetic choice is particularly interesting because it's a very easily modifiable perioperative factor. Previous systematic reviews in cancer surgery have mainly focused on long-term outcomes, such as recurrence and survival. These systematic reviews have mainly been of retrospective studies, and those have shown potentially a survival benefit. However, large randomized control trials have come along, directly comparing TIVA and gas anesthesia, and these have shown that there's not really a difference in long-term survival between the two. Our study focuses on intraoperative outcomes because these are directly relevant for the anaesthetist managing these patients day to day. The aim of this review was therefore to systematically evaluate randomized controlled trials comparing TIVA and inhalational anesthesia for intraoperative outcomes in colorectal cancer surgery. We were interested in all of the outcomes within the papers, but particularly physiological variables, blood loss, anesthetic drug requirements, stress response markers, and inflammatory markers. The review was designed in line with PRISMA 2020 guidelines. We searched Medline, Ovid, Scopus, and Cochrane Central. And we included randomized control trials comparing TIVA and inhalational anesthesia for colorectal cancer, where intraoperative outcomes were reported. We then applied the Cochrane Risk of Bias 2 tool to assess risk of bias. This is a PRISMA flow diagram for our study. Overall, we concluded 6 randomized control trials, and these studies included a total of around 480 patients. This summarizes the results of the risk of bias assessment. The ROB2 tool looks at the possibility of bias arising at 5 different stages of a randomized control trial, namely randomization, provision of interventions, data collection, outcome measurement, and reporting of results. In other words, it looks at whether limitations in study design, conduct, or reporting could be influencing results. The take-home message here is that the studies aren't really of the best quality from a risk of bias perspective. 4 out of 6 studies were deemed to be at high risk of bias. One was that some had some concerns, and the other had a low risk of bias. For 3 of the high-risk studies, the high-risk rating was assigned solely because it was unclear whether there was any missing outcome data. These are the 3 columns you see at the bottom. This slide summarizes the included studies. The studies came from a range of countries, including Romania, Poland, Korea, China, and Sweden. There was heterogeneity in both the anesthetic techniques and the reported outcomes. All of the studies used target-controlled infusions, but some others used just sort of standard propofol or opioid infusions. The inhalational techniques varied between sevoflurane or isoflurane-based approaches. And then the reported outcomes are summarized in the final column over here. So on to results. Looking first at physiological variables in blood loss outcomes, overall, the findings were broadly similar between TIVA and inhalational anesthesia. 2 high-risk studies reported no differences in blood pressure or oxygen saturations. There was potentially a lower heart rate in one of the high-risk studies, but I wouldn't assign too much importance to that, and the clinical significance is uncertain. Blood loss was also broadly comparable between the TIVA and gas techniques, and there was no significant difference in transfusion requirements according to one study. We next examined anesthetic drug requirements and BIS monitoring. Total remifentanil dose and plasma remifentanil concentrations were similar between the TIVA and inhalational groups. BIS findings were inconsistent. One study found no difference, while another study that was high risk reported higher BIS values during abdominal exploration with TIVA. Sorry, that should be lower BIS values, but they didn't provide numerical data for this. Interestingly, one low-risk study suggested that rocuronium requirements might be higher with TIVA. A possible explanation is that volatile agents suppress spinal motor reflexes more effectively than propofol-based techniques, thereby reducing neuromuscular blocker requirements. This is in keeping with a 2018 systematic review of randomized control trials, which found that inhaled anesthesia was associated with a lower consumption of muscle relaxants in a meta-analysis of 11 studies. So this finding does seem to have some legs to it. We then looked at stress response and inflammatory markers. A high-risk study reported lower serum adrenaline concentrations with TIVA during abdominal exploration. However, noradrenaline and cortisol levels were otherwise similar between groups. Another study reported lower whole blood viscosity with TIVA across multiple shear rates. However, baseline differences were also present in the study before induction, so these findings are very difficult to interpret confidently. Finally, most inflammatory markers, including IL-8, myeloperoxidase, IL-17, ICAM-1, VCAM, and L-selectin, were not significantly different between groups. So that overall, I'd say there's no consistent evidence of major inflammatory modulation. In summary, the available evidence suggests that intraoperative outcomes are broadly similar between TIVA and inhalational anesthesia for colorectal cancer surgery. There was similar hemodynamic stability and analgesic requirements. There was some evidence that there's potentially increased rocuronium requirements with TIVA. And there was some evidence for lower inflammation with TIVA, but this was in high risk of bias studies, so I wouldn't assign much weight to it. Back to the finding that there was potentially an increased rocuronium requirement with TIVA. This is the one finding that I'd maybe take away from today that could influence your future practice. It does agree with previous systematic reviews, and it might be of relevance for colorectal cancer surgery in a robotic setting, where having your patient well paralyzed is more important. Otherwise, I think the main conclusion from this systematic review is that the decision between TIVA and inhaled anesthetic for a patient undergoing colorectal cancer surgery can be based more on how TIVA and inhaled anesthetics work in your hands, and there's not strong evidence favouring either technique for intraoperative outcomes. Looking ahead, there's clearly a need for larger, higher quality randomized control trials comparing TIVA and gas anesthetics for colorectal cancer surgery. And there's ongoing work to look at post-operative recovery and long-term mortality in high quality randomized control trials as opposed to retrospective work. Thank you for your attention.
Which kind of anesthesia would you like to receive if, God forbid, end up with needing that kind of surgery?
I think from my perspective, I know that I'm a young female that gets motion sickness and does not smoke. So I know that I'm at higher risk of post-operative nausea and vomiting. So I guess my personal preference would be to have a TIVA anesthetic, just because I know that's associated with lower post-operative nausea and vomiting. But otherwise, I don't think there would be much difference between them.
Okay. Any other question?